very much to the chairs. Thank you for the organisers for the invitation. It's always exciting to discuss a new immunoglobulin product. In fact, I'm not going to discuss that, but I hope I'm going to set the scene for the following talks about the product. I'm going to concentrate on individualization of care. These are my disclosures. And over the next 20 minutes or so, I'd like to speak about the routes of administration and some of the fundamental differences that would perhaps help us choose and better define what fits best for each patient. Cover the options available, some practical differences, and some patient profiles as to who might fit where, and give you just a little bit of data about the Immune Deficiency Centre for Wales cohort to see how that's panned out, perhaps compared to your own experience, and then wrap up after that. So I'd like to begin at the beginning. You'll all recognize Colonel Ogden Bruton, who in fact, more remarkably than I originally first thought, not only discovered a new disease, he discovered a treatment for it, and then went on to define, in fact, one of our newer options, which was lost and rediscovered, which is in fact facilitated immunoglobulin. So he was the first person to use, I'm sorry if the pointer's a bit dim, hyaluronidase to facilitate immunoglobulin. So quite a sort of visionary situation starting right at the beginning. Thank you. So just to start, subcutaneous and intravenous immunoglobulin, and beginning with intravenous, there's clearly a two-compartment model that has been the best used to kind of try to understand what happens when you give this complex, looks like just my finger wasn't strong enough. There we are. To give this very complex medicine, and I'll be covering and comparing and contrasting this as we go through. So initially, there's a peak after you give the immunoglobulin, and then a steep decline, and then a flattened curve. So this steep decline reflects equilibration between the vascular and extravascular space, and here, uniquely for immunoglobulin and albumin, a rescue system through FcRn recycling, so we don't see first-order kinetics dropping off. We see a rescue, which reflects the body's and nature's importance that it places on these molecules. So in fact, when we think of intravenous and subcutaneous, the decision is no longer binary. There aren't just two things to choose from. And I think you'll appreciate the difficulty that this lady has when she's thinking hard about choices here. And that's it's tough, you know? And so here, this is going to look good, but are you going to be on grass? That's going to be tricky. You might go for something else there. So what are the things that play into these kind of decisions? And one of the lovely things about looking into these shop windows is that you can get to perhaps inspire and collaborate with real kind of fashion megastars. So here we have Christian Louboutin and the signature red of the base of the shoe. I'm at risk of losing half my audience here. I do appreciate that. But bearing with me, I think you can see, and we all should take some credit, I think, for inspiring these highly desirable shoes that he makes. He's actually looked at this beautiful IV curve and thought, well, hey, that's going to be great for one of my shoes. And in discussion and collaboration, he's worked through that, facilitated, well, actually, that would work too. And then bi-weekly, and then weekly, and then the more comfortable end of the, rapid push. So it's a lovely collaboration to see with fashion. Of course, even when one collaborates, one has to keep a weather eye on the competition. And what things should we look out for in immunology? And some of us in the room will also look after allergy patients. So this is a, look to the future. It's from a, it sits in the, it's not quite the New England Journal, but it's not far off. It's from The Onion. And this is a product that was put up where, in fact, a blow dart has been developed. And it combines, as it says, the kind of fast-acting projectile medicine, the proven effectiveness of Benadryl with the deep penetrating power of needle-sharp tungsten. So, I mean, great. And Benadryl Pierce, that's a focus group, provides your unsuspecting family members with much-needed symptom relief from distances of up to 30 yards. So, I mean, we're not quite there yet, but it's worth just thinking about what's out there. So, thinking about the fundamental differences between the subcutaneous and the intravenous route. And the intravenous route, we've talked about the PK, and here the antibody molecule has a much more direct route into the vascular space. And we talked about equilibration. But the subcutaneous route is fundamentally different. So here's a cartoon of a needle. We're in the subcutaneous space. Immunoglobulin is too large to go into blood vessels. So it goes into lymphatics, these little cartoon structures here, passes through lymph nodes, notably places where there are many immunological cells, passes up into larger lymphatic structures, the cisterna chyli here, and then into the blood. So here, if one has antibody molecules passing through this system, potentially one might imagine differences in kinetics and maybe differences in function that we can tap into. So it's important to consider the lymphatic space, and it's kind of a bit, to me, going back to kind of medical student days, but in fact, it's a space that is occupied by our treatment, or our treatment passes through. So it's important to think about a little bit. And it's the main mechanism of return of immunoglobulin to the bloodstream. Lots of things can influence how fast that space moves fluid, such as hydration state, exercise, anesthesia. And as you know, following plasma exchange, there's rapid equilibration from the extravascular space back into lymphatics. And it's very rich in lymphocytes. So potential interactions between those molecules and those cells. Hard space to study, though. We've looked a little bit at what subcutaneous immunoglobulin looks like in the subcutaneous space with ultrasound. And I apologize that these are small, perhaps from the back, but on this side here you see a conventional subcutaneous infusion, and on this side a facilitated infusion. And perhaps just to draw out 2 or 3 differences. Here, at the end of the infusion, you can see that the depth, so this is skin to start with, that little space, the space expands, they look pretty similar down to here, and then you can see that actually conventional fills a lower depth than the facilitated. If you have very good eyes, you'll perhaps see that the interfacial planes, black is liquid, are more filled here than here. And if you've got even better eyes, you might see a difference in the granularity. Maybe this is more granular and white, I don't know if you can see it, and here is more diffuse. So even on ultrasound, you can appreciate that subcutaneous space is different as well. And that reflects then into the bioavailability that we see. And these are, again, facilitated in red, plateau phase subcutaneous, and the intravenous curve that you saw. And because bioavailability is assessed by the area under this curve, almost by definition, intravenous is 100%, facilitated is about 90%, and subcutaneous about 65 to 69. So differences in bioavailability, which is fundamentally different from trough. If you switch IV to subcut, you might see a 15% increase in the trough level. So one has to bear in mind these are different measurements. So in terms of practical considerations, while one has these choices in terms of products, and routes. From a patient perspective, and very much that's at the center of things, of course, the place is very important as well. And so if you're thinking about your own practice and these options, what is going to fit best for each patient? And those are going to be potentially very different. There are a number of possible influences that you might think about on that decision-making process, and people might think about the frequency of infusions, how much dose is needed, what the volume is, how do people have a carer or someone at home that they can do infusions with. And this whole spectrum is now available. That's a real big change for us. We have quite a lot on offer for patients. And interesting to note that this intermediate zone where you can use a subcutaneous infusion over really almost user-defined from daily to twice to bi-weekly, some of the evidence that we've gained for the literature has been from not studies but mathematical modeling of existing studies. So we've been very, if you like, ingenious in trying to evidence that all of these options are good and available and can be individualized. In a little bit more detail, one can see particular differences between these routes, and I'll just pick out, for example, some of the timing differences. And of course this will vary, but in fact, thinking about it, you might consider a subcutaneous infusion to be quicker. You might ask a patient, they say, well, I like it because it's quicker. But if you add it up, it isn't necessarily quicker, but it's about perception. So again, those discussions are very much involving the patient. I've pinched a slide from Emily Carn, who's our immunology specialist nurse, and she makes the point that sometimes there are differences in time, and I think she makes it politely here as well, in terms of the diagnostic and explanation and some of the aspects that are covered in a very defined clinic appointment, whereas actually sitting down on an infusion unit, seeing other people, talking through things with the nursing staff, it's an integral thing, working together with the patient. So again, from Emily here, a range of things that might be discussed. I won't go through them all, but I can pick out some. For example, needle phobia. That can play a particularly big role for some people. Some people might be afraid of blood products. And these are things that need to be aired and discussed and worked through. Compliance. How are we going to check that? Someone works, I think my thumb is losing power is the thing here. Work-life balance, lots of travel, more infusions, less infusions, lots of things to consider. When you've come to a conclusion, though, and you feel it is the best conclusion for that individual between us all, remembering that it is not a fixed entity, that in fact, over time things may change. You may not be a child anymore, you may be an adolescent, you may be at university, you may have a busy job. You may find your veins are no longer as good as they were. And so here it's a process of revisiting that it is still the best, and that of course depends on the knowledge which is held perhaps amongst us and our nurses, and making sure that that is transferred so that informed decisions can be made. It might be that new products become available, new routes, or a clinical trial. Patients would be, maybe very interested in participating and giving something back. So those are all possible ways by which you could change the option that was originally settled upon. So just thinking about intravenous immunoglobulin and some, not all, but some considerations that might tend to move you towards that as a consideration. The cartoon here is really to remind me that my preconceptions about what I think might be right are so often not so, and that really the patient is at the center of this. And so you have here, of course, patients where you feel actually they need a higher dose, and that might be more difficult to achieve with other routes. So patients with X-linked A gamma with end organ damage. We know that patients with granulomatous complications actually need more, and maybe their use of immunoglobulin is less efficient. Anecdotally, cytopenias, I'm not sure if that is completely true. Less needles, less frequent infusions, less involvement. Of course, that's different if you're at home. It's a lot of involvement if you're giving IV at home, which we can in the UK, and I know varies across health systems. But some people will come in and say, I would not do my own plumbing. I ask a plumber to do that. Please give me my infusions and take it away from me. So there's lots of different factors there. Subcutaneous. Different thoughts again. And here, just to remind me that it is a question of perspective. So if I think one thing, a patient might think another, and we might be looking at exactly the same thing. And here, of course, children. Much more difficult to find a vein. The flexibility, more likely, more easily to get home. Maybe wear-off effects for some people. So lots of things that feed into that. So just to show you how our cohort pans out, and this will be, I expect, very different across different immunology centres. 200 and something patients, and the yellow bars are children, so we have mainly adults. But you can see that for children, it's really very much a tired thumb. But the yellow bars, subcutaneous, and much less intravenous immunoglobulin at home. Subcutaneous has grown for us and grows steadily. And while we still have home self-administered by the patient intravenous immunoglobulin, it's kind of rebalanced itself. And we're seeing rapid push emerging now as a treatment option. If I combine them all, you can see that, in fact, intravenous immunoglobulin is still a big part of things, but subcutaneous for us has perhaps dominated more. Easier to see on the pie chart. So this is subcut, and this is intravenous if you add these two together. So it's not quite 50-50 anymore. We've kind of tipped a little bit towards subcutaneous. One of the important things for patients is, where can I have my infusions? And then re-looking at the cohort to just ask how much is in hospital and how much is at home. In fact, it was a very clean split for us, with 2/3 at home and 1/3 in hospital. And there are numerous drivers for that. Some of them are the things we've talked about for patients, and some of them are external, to do with commissioning structures or remuneration or availability. So sometimes they are not entirely in your or the patient's control. So just to kind of conclude, we have seen, I think, a huge widening of choice with all of these described options for patients and for us. An understanding of what the physiological differences are helps us, I think, choose in an informed way. And individualization is an ongoing process and is revisited perhaps at clinic appointments, perhaps when people come in for their infusions, perhaps when they ask, perhaps when you have a clinical trial and you think, this would suit X, Y, or Z really well. Let's see if they're interested. There are a range of profiles, and it's a question of trying to interdigitate the options, the patient's views, the nurses, the doctors, to reach what fits best for that individual at that time. And it's, of course, again, with we're humble in our inspiration here for Christian Louboutin. Thank you for your attention.
Thank you very much, Dr. Jolles, for an excellent presentation. We are lucky to have at least 5 minutes for questions. from audience for some our lecturers.
John, thank you for your presentation. Just a question, you showed us a slide for percentages of sub-Q and IVIG, home and others, but the references was not there. If you go back to the slides,
Yes.
the reference for the percentage of population who are getting IVIG and the others who are getting sub-Q, the reference was not there in the slide.
So if it was our own cohort, that's not published data, it's simply in preparation for the talk from our centre. I recognise that different centres will be very different depending on lots of factors, so that's an unpublished data. But in terms of there's a quite nice review on options, which I can give you the reference. It might be in the book, I'm not sure. But that data was unpublished and in preparation for the talk here.
Yeah, and the other question is that the changes that we saw in the skin in the ultrasound, how much that can affect the infusion and the concentration of the immunoglobulins in the patients? After how many months these changes happened, first? Second, how much this affect the concentration of IgG or the IgG level in the patients? And was there any solution, anything, any changes that we should do in order to avoid and prevent that from happening?
So if I read you correctly, in terms of the pictures that were shown,
Yes.
that was, the print will have been almost micro dot, but it's a single infusion and taking images with ultrasound across 15-minute, half-hour slots going down. So all of those changes were very immediate as the infusion went under the skin, comparing subcutaneous and facilitated, and of course also transient. So within perhaps 24 hours, you would not see those changes. The images at the very top were, of course, before any infusions were initiated, but they're patients in whom they're having ongoing infusions weekly, or I think in this case it was bi-weekly or 3-weekly for the facilitated. So you're starting with essentially normal skin. You're seeing the infusion develop over 90 minutes or so, and then we didn't continue beyond that because that was the end of the infusion. The difference in concentration would have been that one was a 16% and one was a 10% in that case. So definitely differences in concentration. The facilitated has a lower concentration, but you might well say, could it not also have 15 or 20%? And I suspect you'd be right about that.
And any long-run effect of the skin changes?
With subcutaneous infusions?
Yes.
So it's a good question, and people ask it a lot. And because obviously the bulk of side effects are local side effects that we see are redness, swelling, itching, sometimes pain. They are generally transient and they generally lessen as infusions progress over time. If we were to look at someone, for example, who has had repeated subcutaneous infusions at the same site again and again and again and again and again for years with, say, facilitated, and then give them a normal subcutaneous infusion, so no hyaluronidase, it behaves like a normal subcutaneous infusion. You cannot give, 700 mils. You can give the sort of 25, 50, 60. So there's an implication that the structures there are clinically similar, but I'm not aware of histological evidence to support that. But I think the sort of clinical impression is that you have a transient change and that as things are absorbed, the skin actually returns to normal. In fact, strictly speaking, you'd be thinking about the subcutaneous space rather than the skin. The skin is almost a structure above where your immunoglobulin is being infused.
And the last question, I'm sorry, I'm asking a lot.
Pleasure.
The last question is related to the slide that you showed about facilitating IV, so facilitating sub-Q and regular sub-Q. How early in age you start facilitating sub-Q in your center?
So we have a contained experience with facilitated and a larger experience with conventional, as you saw from those slides. Mm-hmm. There are about 15-ish patients that we've used facilitated on, and I know others may have much more experience. Those are patients, because it was a new thing to us, that were selected almost because there was a clinical problem or a clinical reason why we thought that might be a better option for them. So, if you like, it was the more challenging patients that came in first, where maybe you were having just too much volume, too many sites with subcutaneous, and they said, I'd like less needles. So, and so those were all adults. There weren't any children treated in that, and it was our initial, if you like, small cohort of facilitated patients were the ones where you think the current options weren't quite right. Would this fit better for them? So it was an early, if you like, toes in the water.
One thing that was strange, and in the slide, that the duration of IVIG was 2.9 hours. Mm-hmm. The duration of facilitated sub-Q was 2.7, and the duration of sub-Q regular one was about, I think, 6 hours, 6 to 8 hours. As I can remember in my practice, it's given about 1 hour, 1 hour and a half. Yeah. So if it is monthly, will be 3 hours for sub-Q, and push will be shorter, not longer time. And in your slide, push was longer than regular sub-Q.
No, I think, it's really important. There is the perception, I think, that you're right, it's about an hour for a conventional subcutaneous, hour and a half. But of course, if the bulk of patients are undertaking that as a weekly procedure, you would have an hour and a half times 4 for that figure. If you were doing intravenous, and it might be 4 weekly or 3 weekly, you would calculate the number of hours as a per month entity. And I think there is something maybe the slide didn't show, which is, of course, that we're looking simply at the infusion. We're not looking at the time to drive to hospital, time to park your car. Those things are not assessed. So you're right, it's the whole pathway that needs to be thought about, but it was a monthly figure, which is why the subcutaneous, with the setup and each infusion, added up perhaps to more than an intravenous infusion. Mm-hmm. Okay. Does that?
Yeah.
Yeah.
But why push was longer?
Well, because you have to
pushes shouldn't be longer. Push should be shorter time, but yours was the longest.
So if you were to make the calculation of there's a small degree of setup, but the average rate for a push is about 1 ml per minute plus setup. So if you are doing a daily event or a 3 times a week event, the bit at the beginning and the end and the middle all add up across a month. So, and this is, of course, you're looking at a kind of an average look. This isn't one individual. And there will be flexibility about that. Mm-hmm. But you have to sum up all of those individual events across, in this case, a month.
Yeah.
Thank you.
Pleasure.
Yes, we have just only 1 minute for one short question. Professor Granados.
Thank you, Stephen. Just a quick question, but I think that what you show in terms of the distribution of patients that receive intravenous immunoglobulin at home is quite remarkable in comparison with other countries. And although you mentioned that depends on regulations and different aspects in each country, if you had to point 3-4 clues in order to convince or just to make this a possibility in other countries, what would you think that the experience in the UK is in terms of the important points to convince, in general terms, that the infusion at home is a good option, or maybe a good option?
Yes, it's a good question, because this was visited now some time ago, I think, and in most depth by Helen Chappell and the Oxford team, where and this would have been the 1980s maybe, where they looked at many patients and many infusions who had had IV training at home and were doing it themselves. So not with a nurse, immunoglobulin delivered, and they would usually with a butterfly, self-cannulate, perform the infusion, and they'd be trained in what to look for in terms of adverse events. If things happen, to slow down and stop, to recognize things, to have an infusion partner where possible. And this was looked at in terms of historically where we used to prescribe EpiPens, in fact, with a worry about anaphylaxis. And I think immunoglobulin products have moved a long way now. And also, even then, when we voted on it, 100% of the UK immunology community voted to stop prescribing EpiPens because we didn't find those reactions. So while it's a smaller proportion with the growth of subcut, I think it is still an option. And you might say an individual who is independent, who maybe wants to choose their own time and wants to have less needles, and our discussion before about the amount of time per month, perhaps the shortest amount of time per month, I think that is an option we can put on the table. There are thoughts about whether a guideline would help, or maybe even revisiting the safety profile to check whether there are options in other countries where this is maybe possible to bring it to clinical practice. Okay. So it's out there, and we looked at it a long time ago. Maybe we need to look again to make it more real now. But it's a relatively contained number in our cohort.
Thank you very much. Dr. Jolles, please. Next.
Yeah, thank you very much. So we should move.